Perfect. Thank you, Dr. Bishop, for your introduction, and welcome everyone. It's my pleasure to be the presenter for today's ECHO session. So I'm also want to just before I get into this, I also want to just introduce my preceptor, Dr. Jason Wachtel, who is also the MTM pharmacist and also the vice president of Geritom Medical, and he was actually a founder of our MTM program and also the PGx program as well, which we will introduce later. And I will start my presentation first, and I will kind of transition to Dr. Borgen with more information about the MTM and the PGx workflow at Geritom Medical. So to start off, just few background information here. So I think for our audience group, I think we all have this consensus that pharmacogenomic results should be reusable. I think most time when we're talking about pharmacogenomics, it's more in the context of germline genetic variations, and as long as the person will not do like a liver or intestine transplantation, they should have these results applicable to them throughout their healthcare journeys in terms of medication metabolism and to guide future medication prescribing. While even we have this kind of premise, there's been challenges in terms of the integration of existing pharmacogenomic results into the electronic health records or EHR. And there's a couple of barriers that kind of prevent us from effectively embedding the PGx data and into routine clinical care process. And also kind of build another challenge for us to further clarify the real world impact of the existing test results. And there's definitely an urgent need for future studies. Unfortunately, based on my current knowledge, I've not seen a lot of studies looking into these aspects in terms of the real world evidence. So it's kind of a part of some research I've been doing for my PhD research, which I'm going to share a little bit in 2 slides. So before I got into some research data, I just want to give you another piece of background in terms of my focus has been in psychiatry. So for psychiatry-focused pharmacogenomics testing is being increasingly used to guide psychotropic medication dosing and selection. And this is some statistics put together by Dr. Bishop that I think based on the data from the genetic testing registry, and there's been over 78 tests from 36 labs specifically provide pharmacogenomics, like psych-focused pharmacogenomics panels for the neuropsychiatric medications. And you can see that on this bar chart, it's really nice bar chart to show like the number of tests that is for the specific pharmacogenes. You can see that the most the panels that have 2D6, 2C19, 2C9, those CYP enzyme, they're really genetically polymorphic. And you may also wonder, so with those test results available, those the CYP genes, they should also be relevant to those non-psychiatric medications. This is especially important in our psychiatric populations because of the high comorbidities of the medical conditions, and there's definitely an urgent need to determine the extent to which the psych-focused PGx results, they may have potential to influence the non-psychotropic medication treatment as well. So I've been doing some research using the electronic health record data from the AMI Health Fairview. So we've been collaborating with our informatics colleagues, and we built an EHR-based research database to further determine the real-world evidence of the psychiatric PGx test results. So to do that, what we did is, first of all, we had a comprehensive search of the PDF scans of the psychiatric the PGx results, which is specifically the GeneSight psychotropic PGx test. And we kind of did some data cleaning and merged with the EHR data, and we ended up with almost 3,400 unique patient test receivers. They had a GeneSight test reports as a part of their EPIC record. And the first thing I look into is like, what's the actual distribution of those tests in terms of the provider type, the specialty, and also the institution. So you can see that in the middle column on the second plot, that in terms of providers, the most the test was ordered by a provider with a medical degree, but there's also a large proportion of tests ordered by the advanced nurse practitioners and also physician assistants. And for specialty area and the psychotropic focused PGx test was most ordered by someone with a psychiatry professions, but also there's a large proportion of family medicines, pediatrics, as well as others. And even the test results we extracted from Health Fairview's EPIC, but actually there's a large proportion of tests they were initially ordered by an external health institutions, then somehow they got into the Health Fairview EPIC. So specifically, kind of want to highlight the distribution of specialty area. So they actually almost, I would say like 45% of the psych-focused PGx tests, they were not ordered by a psych professionals. And especially from family medicines, if they have the test results, they should have also have a sense to be able to use these test results for non-psychiatric medication, because the other medical comorbidities and the non-CNS medication should be within their scope of practice. So then kind of get into their pharmacogenomic results. So the first thing I did is to look into the predictive future drug interactions. And I focused on the 6 key pharmacogenes reported by the GeneSet report. And what I found is, first of all, over 94% of test receivers, they had at least one non-normal phenotypes. And in terms of our predictive future drug interactions, or DGS, and I categorized that based on individual genotype and the phenotypes, and also the consensus recommendations from CPIC, from the Dutch working groups, and also from FDA tables. I did like for both CNS and non-CNS medications. In terms of CNS, for CNS medications across those 6 genes, so I identified some drug interactions across all the medication with PGx guidance and from different classes, including antidepressant, antipsychotics, and some others. And I have they separate by like all clinically relevant DGIs and clinically significant DGIs. So clinically significant DGIs involve like recommendations such as either the contraindications or suggest a change to alternative medication or significant dosing change. And for all the clinically relevant DGIs include all the treatment recommendations other than treatment as usual. So this is kind of some DGIs distribution for CNS medications. I also look into the non-CNS medications. You can see that it's definitely also their existing PGI results is definitely also relevant to their non-psych medications, which including some commonly used medications such as PPIs for GERD, and some cardiovascular agents such as clopidogrel and carvedilol beta blockers and some others. So yeah, so definitely based on their test results, even they were initially ordered for psych reasons, but they should be relevant and should be utilized for non-psych medications as well. So kind of move a step further to look into the actual interaction with the medications they were taking around the test become available as a part of the EHR. So what I found is over 25% of all the test receivers, they actually had at least one clinically relevant interaction with the medication they were taking around the time of their test results being available. So kind of I summarized into different medication classes for both the CNS medications and the non-CNS medications. So you can see that the test results is more it's very relevant to the specific serotonin reuptake inhibitor, antidepressant, and TCs they were taking around the time of testing. And also just want to kind of put a note out there that this estimation should be fairly conservative, because a lot of our tests they ordered by the non Health Fairview clinicians. They may make a medication changes, but based on their test results before the patient got into mHealth therapy. So yeah, so there's definitely a conservative estimation, and we definitely need to look into further to better categorize the prescribing patterns. So that's some ongoing work that I've been doing. So I don't want to take too much time on this didactic portion. So just a few takeaways from the mHealth Fairview evidence. So first of all, based on our initial query that we found that most of the PGx results, they were stored as PDF, and most of them, they are just like a scanned copy of those PDFs. Then we had some informatics solutions to locate those reports, scans in the EHR, and also we had to have manual extraction of the genotype data from those scans. And in terms of clinical relevance, at least 1 in 5 patients tested, they had results that could affect their current both CNS and non-CNS medications. And so there's significant drug interactions in the non-CNS medications specifically. It definitely highlights the importance of the existing psychiatric-focused PGx data for getting the therapy across the various conditions. So now I want to kind of transition to some program overview of Geritom Medical. I will just turn it into Dr. Zac Borgen.
All right, thank you, Lucy. So yeah, just kind of a quick overview as far as Geritom and what our program does, who we deal with, all that stuff. So we are just a comprehensive pharmacy. We offer pharmacy services, medical supply services, different clinical pharmacy services and programs here to mostly individuals in the state of Minnesota, a few in Wisconsin. We've currently got about 2,000 long-term care facilities, mostly group homes across the Twin Cities, greater metro area. And we are one of 5 UREC accredited drug therapy management programs in the entire country, which essentially means that we have a high set of standards that really focused on these primary literature-driven interventions and really getting down I use the term forensic investigation as far as medications go sometimes, but we're not scratching the surface to really getting into those the nitty-gritty details of medications and really making sure that the interventions that we are sending to providers and making are really going to make a difference. And lastly, we are a pharmacy partner of Altair, which is an accountable care organization here in Minnesota, who kind of focuses in that patient category of long-term care with intellectual and developmental disabilities. I'm going to talk just a little bit more about kind of what PGx looks like here, and that Lucy kind of mentioned this, but we originally had a pilot program back in 2019, and we're kind of looking at really digging back into that and seeing how we can grow this impact in this part of our practice. So quick kind of overview as far as what does the MTM process look like at Geritom. So being that our patients are long-term care patients, we're dealing a lot with nurses and guardians or group home facility managers. And so when we're reaching out to schedule those visits, we're usually not dealing with the patient individually. We're usually dealing with a caregiver, a nurse, and setting up a time to actually go out to their facility, meet with them in person, face-to-face, where we're doing our pre-work, typical look through their medication list, looking for kind of questions to ask, drug therapy problems, things we want to hash out at the visit, in addition to maybe what the patient brings as far as a concern of the caregiver. And conducting those visits with the patient present, but again, usually there's going to be a caregiver or a nurse or even a guardian sometimes who's there to kind of help advocate for the patient and be their medical decision maker. And then after the visit, we're going to come back and we're going to write up our recommendations. We send those off to the provider as necessary. And when we get those back, either in the form of a new prescription or we're getting our actual letter response back to us, we're going to get those changes implemented. And then we do a follow-up roughly 30 days from the initial visit, kind of focus on those changes to make sure that things are going well, and we can then continue to kind of make changes from there as needed. So as far as PGx testing goes and kind of the workflow of how it is implemented here at Geritom right now. So we're gonna, as a pharmacist, identify a patient who might be a good candidate for PGx testing, whether that be, they're on 3 or 4 different psych medications, whether we see them on an oral chemotherapy agent, whatever the case is. That might be during our pre-workup, that might be during the visit, that might be something that the caregiver says, oh yeah, that their last psych visit, their provider kind of talked about this. Like, what are your thoughts? So however that's gonna come up, we're gonna kind of identify it there. And then we're going to get verbal consent from the patient or the guardian to communicate that recommendation to the provider that says, we think that, John Doe is a good candidate for PGx testing. I talked to John's guardian and they're all for it. So we're actually going to reach out to the provider then with that recommendation to complete the PGx testing. And the provider is then going to hopefully sign off on that. And we're going to be able to initiate the informed consent process, any prior authorization as needed as far as insurance coverage goes, get our sample, send off the sample for testing, then we're going to get the results, at which point the pharmacist comes back in to evaluate those results, and then as needed, we're going to reach out to the provider for medication changes. And those results then kind of become part of that MTM visit documentation, which ideally we can hopefully use in the future at some point for, whether it's next year we visit them, whether it's 3 months down the road, whenever something's changed, we kind of have that in our toolbox now for just comprehensive management of the patient.
Yeah, thank you, Zach. I think that kind of concludes our didactic presentation. And yeah, so should we open up the conversation to the audience in case we have some questions or comments?
Yeah, I think that's a good opportunity to get any questions from the audience regarding some of your illustrative research quantifying potential drug gene interactions, as well as the separate Geritom workflow. So any questions from the group before we transition to the case discussion?